Welcome back to Mind Matters with Dr. Ogochukwu Ejiaku. So last time we paused on discussing depressive disorders to address suicide during the month of September, which is Suicide Prevention and Awareness Month. So today we are pedaling back to depressive disorders. We will be discussing a type of depressive disorder called persistent depressive disorder or dysthymia. So dysthymia is a type of depressive disorder that is similar to MDD or major depressive disorder. However, it has less acute symptoms than MDD. It has more protracted chronic disease symptoms, unlike MDD. There are no manifestations of psychotic symptoms in dysthymia, like we have in major depressive disorder. And dysthymia has less discrete episode of illness than major depressive disorder. So in other words, dysthymia is a type of mood disorder that has depressive mood often present. However, it is not as pronounced as depressive mood is in major depressive disorder. And that is why often the symptoms go unreported, which means that the individual goes for years without treatment. In dysthymia, vegetative symptoms are less common. And when we talk about vegetative symptoms, we are talking about sleep disturbances, change in weight and appetite. Causes of dysthymia are similar to the causes of major depressive disorder, which includes genetic predisposition, endocrine dysfunction, abnormalities of the neurotransmitters, and structural brain changes. 5.4% of the United States population, 18 years and older, or 10.9 million Americans, have dysthymic disorder. And people with dysthymic disorder have increased the risk of developing major depressive disorder. Actually, 15% to 25% of people with dysthymic disorder will develop major depressive disorder in their lifetime, according to research. Also, individuals with onset of dysthymic symptoms before the age of 21 have 75% increased risk of developing major depressive disorder in their lives. Women are 2 to 3 times more likely to develop dysthymia than men. Risk factors of dysthymia includes genetic predisposition, having a first-degree relative with major depressive disorder, having a first-degree relative with dysthymic disorder, and being a female. Prevention and screening of dysthymic disorder involves identifying individuals at risk for the condition and educating them about dysthymia, the signs and the symptoms, when and how to seek treatment. Prevention and screening also includes educating our local communities about dysthymia. And of course, by educating at-risk families and individuals and our local communities about dysthymia, we are helping to decrease the stigma associated with mental illness, thereby empowering people to move forward with seeking treatment. Of course, we also want to educate the public about dysthymia and the importance of treatment in symptoms resolution or symptoms control. So which means that early detection, intervention, and initiation of treatment are very, very important. It is also essential to note that due to the chronic nature of dysthymic disorder, symptoms often become part of the patient's daily existence, which means that the symptoms go unreported unless directly solicited by aggressive screening and questioning. And sometimes we have to really be aggressive in screening to get out this information. So, of course, when we are screening patients for the diagnosis of dysthymia, we are looking for that chronically depressed mood that occurs more days than not within a period of 2 years. We are also looking for the presence of that obvious low self-esteem, self-criticism, feeling of inadequate, and incompetence when compared to others. Other symptoms that we will be looking out for when trying to make diagnosis of dysthymia are fatigue, low self-esteem, low energy, poor concentration, difficulty with decision making, feeling of inadequate, feeling of incompetence, hopelessness, mild anhedonia. Of course, anhedonia is lack of pleasure in previously enjoyed activities. It is usually mild in dysthymic disorder. We are looking for isolation, social withdrawal, and subjective irritability and anger. Of course, decreased productivity and activity level. There are no specific physical exam findings in dysthymia. Findings are usually similar to MDD. Mental status exams often shows less manifestation of vegetative symptoms. Of course, again, vegetative symptoms are sleep disturbances, appetite changes, and weight changes. Those are decreased in dysthymic disorder. But mood is often described as sad and being down or feeling down all my life. Also, there are no specific diagnostic tests or laboratory findings in dysthymic disorder, which means that diagnosis is made based on history collected. So this again tells you the importance of thorough history collection and screening. Of course, sometimes there may be need to order some labs such as TSH, which is a thyroid test, vitamin B, vitamin D level. You want to check those things to rule out other possible causes of the symptoms being reported. Comorbidities of dysthymia are similar to those of major depressive disorder. Of course, major depressive disorder is often superimposed on dysthymic disorder. So which means that somebody with dysthymia will develop major depressive disorder. And when this happens, we're dealing with double depression. Of course, when this happens, we start to see more of those vegetative symptoms, sleep disturbances, change in appetite and weight. Those are usually seen more in major depressive disorder. So when someone with dysthymia develops MDD, you start to see more of these symptoms. So when dysthymia precedes major depressive disorder, treatment is often complex and outcome may be less positive. Other conditions associated with dysthymia are personality disorders such as borderline, histrionic, narcissistic, and other personality disorders. So, of course, treatment of dysthymic disorder is the same with treatment of major depressive disorder, which involves pharmacological and non-pharmacological measures. Of course, the pharmacological measures involves using medications from the classes of antidepressants called SSRIs, selective serotonin reuptake inhibitors, or we can use SNRIs or TCAs. With non-pharmacological measures, we're talking about therapy. CBT is always a good one. And actually, research has shown that there is great benefit with using non-pharmacological measures, which are therapies, different types of therapies to treat dysthymic disorder as long as the individual stays compliant with treatment plan. So special consideration involves children. It is important to note that in children, the occurrence rate of dysthymic disorder is the same for boys and girls. And in children, this dysthymic disorder is associated with other childhood conditions such as ADHD or attention deficit hyperactive disorder, anxiety disorder, and conduct disorder or learning disabilities. It is also important to note that to make diagnosis of dysthymic disorder in children, we only need these symptoms to be present. The symptoms that we mentioned earlier, we need them to be present for just 1 year compared to 2 years in adults. So in our future videos, we will address the other types of depressive disorders. Our email address is located in the description. So please feel free to send us your general questions. We will randomly select questions to be addressed in our future videos. So like, comment, subscribe, and share this video with your friends and your families. Thank you all for watching. I am Dr. Ogochukwu Ojiako. Thank you.